Being recorded, excellent.
Yeah, just started it.
Cool. Hello from Turkey. Hello, good to see you. Hope your Turkey's better than here. Hi guys, yeah, so I've got the chat here on my phone, so I'll be able to see messages all throughout. My name's Samir, one of the F2s here. I'm a Leicester graduate as well. I've done quite a bit of teaching as an F1 in Northampton, where I may have met a fair amount of you. I did it for 3rd, 4th and 5th years then, and then a bit of sporadic teaching, virtual mostly this year. Thanks to Tanvi and a hookup with RespSoc and obviously with Anastomose. So yeah, thanks for having me. Today will be a 1-hour talk on cardiovascular emergencies. So ultimately, this is going to be drawing on a bit of my experience, firstly, because I've done a job in cardiology, number one. I'm quite interested in medicine overall, especially cardiology, number two. And pretty much all the cases we're going to go through today are real life cases. So these are things that have genuinely happened. I'll give you a bit more context around them, just because I don't want you to think that I'm some sort of hero and I did all these things by myself. Pretty much every single one I had a team, I had help, I had registrars, all that sort of stuff, but these are things I learned from them. So we're going to sort of package it in a way that we can start to solve some problems, be able to figure out what sort of diagnoses we can find from the information that I'm going to give you, and following from that, how to manage cardiological emergencies and what are the common ones you need to be aware of, things that can be useful for your exams and when you're actually on the wards as well. Okay, there'll be some references to the guidelines for different diagnoses we'll come across as well today. Let's get right into it. So we've got first case, we've got an 83-year-old man. This happened a couple of weeks ago actually, so this one's quite fresh. He's got severe heart failure, aortic stenosis, CKD, and you get a phone call, you're on ACB, and you get a phone call from the general ward saying this man's got a really high heart rate and a low blood pressure, and it looks like he's in AF. And essentially they're calling because they want to transfer him to ACB for further monitoring and additional management. So a bit of context, ACB is sort of a medical HDU in AMU. It stands for Ambulatory Care Bay. It's got 10 beds and managed sort of quite unwell patients, people that might end up going to ITU if needed, but also those who are kind of at a ceiling of ACB, meaning they won't go anywhere past ACB, if that makes sense. With this information, so you've got someone with very high heart rate and a low blood pressure, and someone saying they want to transfer them from a ward to you. What information do you want to know? Just sound off in the chat, guys. SpO2, respirate, very good. Certainly. ECG, certainly. So yeah, for sure. So let's say you're on the phone though. So yeah, you get a handover. How do we hand over SBAR? So truthfully, I've given you, let's say I've given you a situation here, right? And I've given you background, and the recommendation is transfer. I haven't really given you assessment. So here's your assessment. You've got EWS, okay? So this is a bit of a mock A2E, and these tend to supplement your A2E, but you can only do your own personal one when you get there. So yeah, his blood pressure's gotten a bit better. It's 76/55. His tachypneic and his heart rate's a bit better as well. So he's pretty much maxed out on beta blocker. Other information, you might want to know what his ceiling of care is and what the aims of treatment. You might want to say what specifically do you want us to do in ACB that you can't do on the wards. And they had a specific thing they wanted, but we'll get to that. That'll be a bit of a test for you. And finally, the admission reason, that might give you a bit of context as well. So he came in with peripheral edema and some abdominal pain. So you guys clued on quite well. This is the standard stuff. We'll just go right through. For his A2E. So you get to ACB. Airways patent, got some bibasal crackles, slightly reduced air entry. He's a bit tachypneic, but his oxygen levels are normal. Okay. Cap refills 2 seconds, got an irregular pulse, his heart rate is 142, and all the OBS, like I said, his JVP is raised. D is all fine, and he's grossly edematous, peripheral edema. He has no cannula. So the phone call actually came in as this man's, very difficult to cannulate. He's edematous. We weren't sure if there was a peri-arrest that was called at the time, but it would make sense for there to be one. Fair enough, he's got severe heart failure and aortic stenosis, so his blood pressure is always going to be low. So in truth, 76 is low, but if normally he runs at around 90, it's not extremely below his baseline. With that said, can we go through 10 steps of management? I know this is a push. Anything that you think is, however small, that you think is a smart thing to do for this patient, given the information I've given you, what do you think is relevant? IV access, good. Furosemide, at some point, good. IV fluid, maybe. I came up with 16 things, guys, and that's not showing off, just small things, anything you want. Why inotropes? His ceiling of care is ACB as well, so he's not suitable for ITU. Chest X-ray, yeah. Interesting. So what is the issue here? What is the main reason he's come here? He's come in because his heart rate is very, very high and his blood pressure is very, very low. So in a way, and a bit of a general sort of teaching point actually, keep signing off in the chat. Whenever you go through your A to E, you'll learn that you'll tend to stop at a specific letter. So you see a patient, you can always take a bit of a snapshot and realize, okay, this patient's going to be a B. If you know that they're wheezy, you know that they're new oxygen requirement, they're breathless, all that sort of stuff, you know that B is going to be your main focus. If you go to a patient because they're having chest pain or low blood pressures or unstable heart rhythms, you know that C is going to be your important letter. Similarly, if they're wheezy or if they're stridorous, you know A is going to be the important letter. If they're drowsy or unresponsive, D is going to be your important letter. So you get quite familiar with A to E in that sense when you start to apply it a lot more. For now, it's kind of just a nice structure to make sure you do everything right. Yeah, good stuff, guys. So I came up with, why don't I actually show you the things I came up with? So I come out slightly. So yeah, really good stuff, guys. Things like blood cultures, I wouldn't be concerned about. Yeah, so get some help. Nurses and doctor, they'll be there. My registrar was there. In terms of quickly raising a blood pressure, the first thing you probably want to do is raise their legs and put their head down, okay? Definitely want to get IV access. That is absolutely imperative because if this man arrests, we can't resuscitate him. We're not going to do chest compression. The limit of his care is medication, anything that will go into a vein or any supportive measures that we can do. So in a way, we have to, maximize all of that as much as possible to give him the best possible chance. Obviously, everything that's appropriate. Bloods wise, thyroid, magnesium, VBG. You can do a full set of bloods, obviously, but these are specific to whenever you have some sort of unstable heart rhythm. A thyroid and a magnesium are usually ones that aren't part of a standard barrage of blood tests that you do. So just think of those in addition. The VBG just comes back quicker. That's all. You can just see what the potassium is if that's relevant. Obviously a formal 12-lead ECG. He was hooked up to cardiac monitoring anyway. That's lower down blood pressure monitoring for sure. Review his drug chart. There you will see that he's maxed out on his beta blockers. So if he's had bisoprolol oral, you can only really have 10 milligrams in the 24-hour period. Anyone that goes beyond that is usually a cardiologist. So no doctor should be as audacious to pretend to be a cardiologist for those reasons. But yeah, as a general rule, you don't go more than 10 milligrams of bisoprolol in a 24-hour period. So we're maxed out there, we're limited in that sense. His blood pressure is also low, so you want to be a bit careful with that. Is that all right? Does anyone have any questions about the rest of it? Do you want to find out about any history of cardiac symptoms? Because having a low blood pressure doesn't necessarily mean you're hemodynamically unstable. I guess it does, but does he have symptoms? Is he lightheaded? Is he pre-syncopal? Is he drowsy, dizzy, confused? things that you would get with low blood pressure. So yeah, good job, guys. You see this ECG. Y-DNA CPR. He's old and frail. He's got very severe heart failure. His outcomes from cardiac arrest would be very low. I hope that makes sense. That's just a quick explanation. Is it wrong to take ABG instead of VBG? In a way, yes. If I'm giving you advice as an F2 and you're going to be an eventual F1, if he hasn't got a cannula, you put in a cannula. You have to. You've now got access to a vein. You can just take all the blood that you need to, rather than having to stab him twice. Do you see what I mean? So it's wrong in the sense of it's more efficient to just do a VBG. And the reason I chose to do VBG was to look at electrolytes. It wasn't to bother with the gases. I hope that makes sense. I won't dwell too much on this ECG, to be honest. It's just fast AF. It's an irregular rhythm. You can't really see consistent P waves. You might see some shaky baseline. There's irregular amplitudes of a lot of the QRSs, which imply that they're not conducting in a consistent way, which definitely matches with AF. Please ignore the ST elevation. This is just the ECG I plucked off the internet, but good on you if you spotted it. Some ST depression in 1, 2, and AVL, some of the antireceptor leads as well. But yeah, let's just ignore that. So how would we manage this? This guy has AF, right? Now that I've given you the ECG and you've double checked it for yourself, he's got AF, he's got fast ventricular response, and we have to say he's hemodynamically unstable because the blood pressure went down to 60. That's very low. Truthfully, looking at him, he was awake and alert. He wasn't very well perfused, but he wasn't sort of imminently arresting, if that makes sense. But his EWS is 9, so he's critically unwell. He needs ACB. The reason why they brought him here was for chemical cardioversion. So they wanted to do amiodarone. So how do we manage acute AF, guys? What is the approach that we would do? Signs of shock, DC cardiovascular. Yeah, that's specific. What about generally? This is acute management. What is the structure? So they have a high rate and an irregular rhythm. They have a rate problem and a rhythm problem. And obviously now they have a cardiac output problem, which is why it's acute management. So rate control, rhythm control, is that familiar with you guys, yeah? So rate control, we'll go through when you would choose rate control versus rhythm control as well. So yeah, your mainstay for rate control, complete mainstay, is going to be beta blockers, specifically bisoprolol. It's cardioselective, it improves the heart rate, and it does lower the blood pressure a bit. If they can take orally, you give oral bisoprolol. Like I said, maximum of 10 milligrams in 24 hours is suggested. If they're unable to take oral, then you can go for metoprolol, which is an IV equivalent. I think it's pretty much the same doses. Anyway, any reason why they can't have a beta blocker? Any patients? Why might some patients not be able to tolerate a beta blocker? Definitely. So people who have brittle asthma can get bronchospasm triggered by beta blockers. If you think about it, an inhaler is a beta agonist, so that dilates it. Giving them the opposite would constrict it. Truthfully, bisoprolol is cardioselective, so a lot of doctors will still give bisoprolol if someone's got asthma, and they might be more careful if they've got very severe or brittle asthma. And that reminds me of a case I had in my as an F1 as well, where that's fine. I'll get distracted. We're not going to not go through it. Yeah. So in that case, you give them a non-dihydropyridine calcium channel blocker. So the examples are verapamil or diltiazem. You can give either of them IV or oral, I believe. Another one is digoxin. So digoxin is a good one. It is an AV node blocker. So it is a rate control measure. it is used relatively commonly, actually, even though it's kind of an old-fashioned drug. If you have any questions about digoxin and stuff, just sound off in the chat. I don't have much more to say. Rhythm control. You guys happy with this sort of stuff? So if they're hemodynamically unstable, I saw someone said in the chat, you go for electrical cardioversion, okay? Otherwise, you can try chemical. You can go for an elective cardioversion if they're more stable, if it's like a new AF. You want to give them a good period of time with anticoagulation and concurrent amiodarone. Okay. No, we can't give bisoprolol and verapamil together, ever. No, because you can get bradycardia, you can get complete heart block, that sort of thing. You can drop your cardiac output quite a bit. I think these calcium channel blockers tend to have a bigger effect on the force of contraction than than this bisoprolol, but they also are negative chronotropes as well, meaning they lower the heart rate. So you pick one or the other. So I had a patient who was asthmatic, and everyone told me to give bisoprolol, it's fine. But I was fresh out of medical school, and it felt wrong to me. I'd spent, 3 years doing past med questions where I had to avoid this drug because if the patient had asthma, I couldn't give it. But people didn't really care because it's cardioselective, it wouldn't really have an effect. I ended up giving verapamil for a patient in a really, really high heart rate with AF. But we'll move on. So how do you pick between rate control and rhythm control? We tend to favor rate control if they are above a certain age, if they're older, if they've got less symptoms. And generally speaking, you use rate control for the most part. Things for rhythm control is if they're young, if it's a new AF, meaning they've gone into a sinus rhythm into a irregular rhythm, that means the rate of sort of having embolic phenomena are higher, okay? And their heart is not used to that. Their cardiac output will very much be compromised. And if they already have heart failure and they have worsening symptoms because of that AF, you want to get them into a sinus rhythm because their cardiac output is never really going to recover. In this particular case, he had heart failure worsened by AF for sure. He had peripheral edema. He had, left ventricular outflow obstruction because of the severe AS, aortic stenosis. So he was definitely a candidate for rhythm control, which would be amiodarone. So in his particular situation, we got IV access, we kept him on cardiac monitor, and we gave him amiodarone loading, and then we gave him oral anti-amiodarone thereafter. His rate did improve. It went down to sort of 110, 120. So we kind of got ourselves out of that acute period. There's a few mentions of things like anticoagulation. That is obviously important. You should do a CHADVASC and start them on treatment dose dalteparin until you want to establish what type of oral anticoagulation, dalteparin, any molecular heparin, establish them on eventually on an oral anticoagulation, depending on their type of AF, if that makes sense. That will come in the sort of days afterwards. For now, let's sort of sort out his hemodynamic instability. Is that right, guys? Any questions? If not, we can move on. I'll keep my eye on the chat anyway. There's another patient of mine. He's a patient I saw on the ward round, and later on in the afternoon, he started developing chest pain. So the nurse came to me. So a quick question. So no beta blockers for heart failure. If heart failure, go with rhythm control agents instead. Not necessarily. Basically because he had heart failure and he had a compromised cardiac output as a result of the AF. So that was the worsening of his heart failure. It depends. In his particular case, because he had heart failure, he had already had a good amount of beta blockers, because people who have heart failure need to have beta blockers. So then there wasn't even an option to give beta blockers, and he had a lot of rate control anyway. So he couldn't give verapamil or diltiazem because he had beta blockers in his system. We gave him some digoxin as oral as well, but then it kind of just put us into the rhythm category from that perspective. Cool. So yeah, this gentleman is 65. He came to the cardiology ward with peripheral edema, shortness of breath and exertion. So he's got severe left ventricular systolic dysfunction, so heart failure. Previous CABG noted, a long-term smoker. So nurse comes up to you and tells you he's got chest pain and he looks unwell. So what would you do next, guys? If I give you this little scenario. This is the information you've been given. So, I mean, in my head, I can picture, I think I was sat at my desk, I was doing a TTO, I might have been doing a referral of sorts. And at some point I got up to go and see him, but what would you do first? You can choose multiples. And truthfully, I just wrote all of these down. There's nothing sort of right or wrong here. Anything you choose to do is probably correct. Yeah, EWS. Would you ask the nurses to do an ECG first and then you'll go and see him? Do you want to go and see him straight away because the nurse said he looks unwell and therefore you can just quickly eyeball him first and then say, okay, yeah, fine, do an ECG. I'll come back in 5 minutes. I'll do a proper A to E then, you know, all that sort of thing. Are you going to panic and then call the reg straight away? Not panic as in a rude way, but are you going to call for help straight away? You're going to try and manage most of it yourself. The truth is, guys, I don't actually have answers for this. I think most of these are correct, but it's just an exercise to get you thinking about what you would do in what order. For example, if you're in the middle of a TTO and had 2 minutes left to just do a few more medications, but she said the patient's really, really unwell, they're scoring a 10. How do you then start to balance that? Would you quickly eyeball them, come back and finish the TTO? Would you ask the nurse, you know, can I finish this? I'll be 2 minutes and come. If they say yeah, then yeah. It's just about developing a bit of maturity as a doctor. So eventually, yeah, you go and see him. So he appears breathless and clammy and he does not look good. Okay, airway's patent, he's breathless at rest, he's got bisbasal creps, he's tachypneic, SATSA 93, speaking in short sentences. Calorie feels less than 2 seconds, blood pressure is normal, JVP is raised, heart sounds normal, D is normal, and we know he's got edema to his below knee. He looks pale and sweaty to you. So what's going on, guys? What do you think? MI, acute heart failure, pulmonary edema. Yeah, smart stuff, guys. You guys are good. As an additional sort of thing, whenever you start to see respirate that is disproportionate to the SATs, I know the SATs are technically slightly low. Sometimes when you see a tachypnea with normal SATs, you start to think, that can be caused by pulmonary edema. So he's definitely got peripheral edema. He's definitely got, we've established he's got severe heart failure anyway. Has he got a sudden worsening of that, given that he's now short of breath? Given that he's breathless and clammy, we're definitely thinking MI, so yeah, good stuff. So the ECG is done, you've done your ATE and it shows up as this. What do you think? And what are you going to do about it? What's the most obvious abnormality? So normal, abnormal, worried, not worried. Are you going to sign normal sinus rhythm, put in the notes and then go back to your TTO? Are you going to call your reg? T-wave inversion, very good. I've got a little thing covering a bit of my slides actually. Can I move it? Oh, I can't move it. Okay, I'll move it. Yeah. No ST elevation, T-wave inversion, V1 to V5, V6 is fine. Right ventricular hypertrophy. Truthfully, I don't know the criteria for voltage criteria for RVH. So I'll believe you if you checked up on your notes. if it satisfies the criteria, then I'll agree with you. P. pulmonale, I don't think so. It's usually quite big, P. pulmonale. Usually LVH is very, very deep S wave, V1, V2, and very, very tall R wave in V5. No, lead 1 and lead 2 are both positive, so they can't have any axis deviation. That is a quick trick. So yeah, whenever you get an ECG, if lead 1 and lead 2 are both generally positive, then the axis is normal, it's in a normal range. In order for it to be axis deviation, generally speaking, lead 2 will have to be at least isoelectric or negative, and then you look at the leads either side of lead 2 to see which direction it's going in. So if lead 1 ends up being really, really positive, then it's left axis. If lead 3 and AVF end up being really positive, it's more right axis. I think the main thing is just the T-wave inversion. We don't have to spend too much longer on this, but the diagnosis, yeah, exactly, thank you, yeah. The diagnosis is a N-STEMI because there's no ST elevation. So we're going to talk a bit about ECG changes. So this is something that also gets covered a lot. You'll talk about the T-wave inversion or the hyperacute T-wave, the ST elevation, the Q waves and stuff. When thinking about N-STEMI, this is actually something new that I learned. You think specifically about ST depression and T-wave inversion. T-wave inversion is something I've seen far more commonly, and truthfully, I've seen a lot of ECGs with not significant ECG changes at all, but with a significant troponin rise for patients with these sorts of cardiac sounding chest pain. And that's how we've diagnosed an N-STEMI. So it doesn't even need, a very, very convincing ECG in order to do that. In any case, if we're talking N-STEMI, you're talking subendocardial ischemia rather than full thickness. And usually that presents as widespread ST depression. If there's localizing ST depression, that is more so representative of a reciprocal change, and you should be looking for an ST elevation in the opposite lead. But yeah, T-wave inversion localizes to whichever artery would be impacted. And bear in mind, there are normal variants of T-wave inversion. So in QRS complex leads where they're generally negative, having an inverted T-wave is normal. So you kind of want a T-wave inversion in homologous leads, so like two that are next to each other. Similarly, you want to look for dynamic changes. So you want to do serial ECGs. That's going to be really, really important. So how do we manage ACS? If we're calling this acute coronary syndrome, firstly, what is ACS? Can someone tell me, and what would you do to manage it? You can just blurt out anything that comes to mind, and I'm sure you'll be correct. Yep, and it's a triad, isn't it? What is it a triad of? ACS, acute coronary syndrome. Good job. STEMI and STEMI unstable angina. Okay. So stable angina doesn't fit into ACS. Yeah, it would fit into ischemic heart disease. So ischemic heart disease is ACS plus stable angina, if that makes sense. There's a lot of mnemonics, obviously, for medicine. Cool. How do we manage it? This guy's got an N-STEMI. He's pale and he's clammy and he looks terrible. And you're on a cardiology ward as well, which is good. Yeah, what's Mona? Yep, morphine, oxygen, nitrates, aspirin, definitive treatment. So if we break it down a bit, there's investigations you could do. There is initial drug treatment. There's supportive measures. Okay, and we need to start to think about why we're giving all of those. Okay, so I've kind of just blurted them all on the screen myself. So I mentioned obviously the serial ECGs. In this particular situation, we need to do a troponin. We have a good reason to do a troponin as well as the other blood tests. If you're significantly anemic, you can obviously get N-STEMIs because you get reduced oxygen supply to the heart muscle. You want to see what their user-needs are like because you're going to give them medications that you need to know their kidney function for. And close monitoring and tight glycemic control is good is essential for diabetics. Your registrars are all trained to do echoes. So you're in a good place. They can do a bedside echo for you. They're looking for regional wall motion abnormalities, and you can do an LV assessment. You leave that to them, but just as long as you requested an echo at some point, that's fine. The most important thing is probably going to be this middle section here. And if there's anything I want you to take away from this talk, it is this. All right? Because Mona is all well and good. Mona is effective, but it puts equal importance of each letter on all of them. So the M, the O, the N, and the A. Most of the time you won't need oxygen. They should have good analgesia, which is what M represents. But you want to make sure that you give them antiplatelets. And so we're talking about something called ACS protocol. If you've not heard it before, you'll hear it spoken about quite a lot. So ACS protocol is specifically 2 antiplatelets and some sort of anti-clotting agent, okay? Well, not some sort of, specifically fondaparinux or low molecular weight heparin, all right? So always gonna be aspirin. It's 300 milligrams as a loading dose. That is kind of a first aid thing. So if you have a family member who's got chest pain that sounds cardiac, yeah, that's the aspirin under the tongue kind of thing. Excuse me. The second antiplatelet usually depends on the cardiologist. Sometimes it depends on the type of MI. To keep it simple, I keep it simple. I just think aspirin, clopidogrel, and then we start to think about what type of heparin we give. So fondaparinux in NSTEMIs, yes, it's also something I think you need to stop it if you're going to do a PCI because it confers bleeding risk for that. I've had a lot more experience giving enoxaparin in this regime. You'll need to know this regime as a doctor. You don't need to know it for your exams. As long as you know 2 antiplatelets and one of these 2 as ACS protocol, I'm happy with you guys, yeah. Standard GTN, of course, you guys mentioned that earlier, so yeah, good job. And certainly the definitive management is a PCI. So that's an angiogram and angioplasty. So the gram is flushing contrast and looking for the stenosis. The plasty is putting in a stent to scaffold open. I've heard that clopidogrel is preferred if patient is at risk of bleeding. Is that right? Should patients be on unfractionated heparin prior to PCI? Is that what UH means? So ticagrelor confers a higher bleeding risk. Prasugrel is preferred for STEMI. Clopidogrel still has a bleeding risk. The truth is, you know, you need to do kind of a risk benefit in any situation. If they're having a heart attack, that's bad, bad, bad. So it's not the worst if they end up with a bit of hematuria for a couple of days, in which case you end up just, you know, scaling back on one of your antiplatelets at that point. But yeah, that certainly is a good question. I would consider clopidogrel to have a lower bleeding risk than ticagrelor and prasugrel. So I hope that answers your question. Should patients be on UFH prior to PCI? In my experience, no, because we PCI people with NSTEMIs as well as STEMIs. We just do it a bit slower. So I haven't actually managed any STEMIs, and I think there's more of a role for unfractionated heparin for STEMI. Truthfully, it's this low molecular weight heparin that is the substitute for unfractionated heparin. But certainly within the actual procedure, the cardiologists are consistently flushing the arteries with heparin. So again, that's something that they can manage, they can deal with. As long as you've given the loading doses of the aspirin and clopidogrel, yeah, they're fine. Does that all make sense, guys? So the important thing is obviously the antiplatelet. The echo is really important, and serial troponins, serial ECGs are extremely important, okay? So the Mona is quite easy to remember as long as you add on thinking about serial ECGs, the serial troponins, and slightly more specific on the dual antiplatelets, okay? Yeah, loading dose for aspirin and clopidogrel is 300 milligrams stat and then 75 once a day. So these doses are exactly the same. Trop baseline and then 12 hours later. Yep, that's certainly correct. Truthfully, you can do a trop. Different trusts do it different times. Sometimes you can do 3, 6, or 9 hours. As long as you've done a trop, I would say in a smart period of time afterwards, because all you want to see is a rise. And any sort of period of time is actually okay. So sort of 5 hours is fine, 10 hours is fine, all that stuff. You're going to be too busy on wards to be timing troponins to the absolute T. Okay. But yeah, good question. You guys are smart. Should we move on? Any more questions? I put a lot of detail on this slide just because you guys are going to keep the slides, so it's probably best to have more, but I think it's made me talk quite a lot about it. So let's press on. So this happened, I think, 2 months ago. This lady is 75. I was working in renal. She came in initially with vascular access issues, fine. She's on hemodialysis 3 times a week. She was about to start it when the alarms were pulled, so the nurses were with her, and they said, "Doctor, heart rate's 30." And you start to think, "Oh shit," for obvious reasons. I think bradycardia is one of the things that scare me quite a bit. But yeah, you're the first one there. What are your immediate instructions, and what are the subsequent steps? Tell me. Peri-arrest, ALS guidelines, adverse features, atropine, don't do hemodialysis. You guys are good, man. You guys will be great. I was panicking, but you guys would keep a nice steady head given these decisions. Slightly going back to that question, Hannah. Yeah, if they get stented, you do dual antiplatelets for 1 year, and then you can continue aspirin lifelong. If they don't get stented, I don't think they need clopidogrel for as long. They can stay on aspirin, yeah? Especially for NSTEMI. So my immediate instructions, if I was super smart, would be get the crash cart, check her blood pressure, and then, yeah, peri-arrest would be smart. I think if there's going to be 3 things I would do, is I would check the pulse again myself manually, and I would check her blood pressure straight away, and I would get someone else to bring the crash cart. All 3 of those things. The atropine is coming, guys, and then the peri-arrest is coming. But in terms of you're there in the first 5 seconds, this comes with reflection and a lot of reflection, and a lot of experience. What is the immediate instructions you're going to give that are going to be the most helpful? Because if her blood pressure is okay and normal, you don't give atropine, number 1. We'll get into A2E. And if if the reading was done on a SATS probe and it was done incorrectly, you pull the peri-arrest, you've pulled the atropine out of the cart, and it turns out our heart rate is actually 55, and maybe it's a bit irregular. Do you see what I mean? So those are the kind of immediate things, and then there's sub-immediate things. So yeah, a lot of commotion happens because the alarms are going off. It's a lot of stress. She sat there comfortably, but she's babbling away. She's got a lot of personality. She did. But I was more than happy to have that. So airway's patent, as patent as it can get. She's breathing comfortably. Her pulse is regular and slow. It was about 42 beats a minute, and her blood pressure was 88/57. So she's definitely got a low blood pressure. She's hypotensive and bradycardiac. Symptoms-wise, she's not hemodynamically unstable. Numbers-wise, she is. And hemodynamic stability kind of hinges on both of those things. D is fine. E, she wasn't put on dialysis, pardon me, and the crash cart was pulled to the bedside. She was immediately put on a cardiac monitor. So the pads that you apply to the defib machine can also act as a cardiac monitor. So it doesn't mean that you're impending to give a shock or cardiovet or what have you, or pacing, but it acts as a cardiac monitor. And she was certainly bradycardic. With this information now, are we happy to give atropine? Is this a good reason? Is this an indication for atropine? She's bradycardic with a low blood pressure. Because she's sat up and feeling okay, you feel reassured for sure. She's not arresting in front of you, which is very good. And I'm ecstatic to say that. But yeah, it is an indication for atropine. Yeah, low blood pressure is below 19, below 60. So yeah, I know what you meant, don't worry. This is the ECG you see. Someone asked me what is the cause of the bradycardia. Well, you tell me, what is the cause for the bradycardia? And what do you see here? Good or bad, fast or slow. Ectopic beats. No, I wouldn't say ectopic beats. They look abnormal, I suppose, in a few areas. So I kind of see what you mean about ectopic beats. Am I right in saying you're maybe looking at V2 around V4? These ones, they look a bit funky in terms of ectopic beats. Yeah, I know what you mean. It just looks abnormal. It's just how it is. They're Q waves, by the way. These are Q waves, and then an upright T wave. So a bit of a T wave going on there. There's no R wave here, but the T wave is quite. I think it looks weird because if you didn't have sometimes you can get tiny R wave, big S, and then whatever T. Because the T looks quite high relative to any R wave, that's why it's making it look abnormal for you. So you're picking up on something. Your instincts are telling you it looks abnormal, which is good. AV block type 3, probably. I can't really see P waves. It's not the greatest ECG. I just pulled this off the internet, but this could also be. So complete heart block, central electrolyte abnormalities. Which electrolyte? Someone mentioned, oh, you said, yeah, hyperkalemia. Yeah, so hyperkalemia, you can get bradycardias with it. And we've established that she was just about to have hemodialysis. So in theory, she's at a point where her potassium is at the highest it's ever really going to be. So yeah, these are ECG signs. The most likely cause is potentially hyperkalemia. So you do a gas, and this is the gas. So a bit acidotic, normal gases. Potassium is 7.4, it's high. Bicarb is low, it's probably chronically low because she's got end-stage renal failure. What comes before insulin? Calcium gluconate, excellent. What does calcium gluconate do? Stabilizes myocardium. Excellent answer, AMS. Very, very thorough. So let's say it's a normal patient who's not on hemodialysis. You've got someone with ECG changes. They may not be the standard, tall tented T waves with broad bizarre QRS that you see with flattened P waves. But truthfully, there were some T waves that are a bit higher than the normal. So I would call these peaked. I would definitely call these peaked. And I would just compare it to a previous. They've got bradycardia, so that's caused by the hyperkalemia. This is a definite indication for calcium gluconate, and that stabilizes the myocardium, which is what the answer is, of course. The patient is already established on hemodialysis, so it's not really a situation in this particular case of hemodialysis if refractory, but in a normal patient, absolutely correct. In a normal patient, it would be obviously the following. So specifically insulin with dextrose after you've given the calcium gluconate. Additional measures are salbutamol nebulizers, and calcium resonium is a bit more definitive in reducing any absorption of potassium from the gut, and that takes longer to work. So all of these stuffs are slightly more acute than that. If it's refractory to medical treatment, you would consider hemodialysis / ultrafiltration, and that would be a discussion with either renal or ITU respectively, okay? And if they say no, then you have to find another way or cut your losses or treat the cause. That's when it can get tricky. And calcium doesn't do anything to reduce the potassium. You guys happy with that? So the cardiological emergency is bradycardia. The hyperkalemia is sort of a side thing. What we did identify well was hemodynamic compromise, so confirmed low blood pressure, systolic and diastolic, with the bradycardia is an indication for IV atropine. So you give 500 mics as a stat dose. You can give multiple doses up to 3 milligrams, okay? And you keep them on cardiac monitoring. You probably take some bloods. You did that with the gas anyway. Definitely include a thyroid function test just in case they happen to be low, because that can be a cause. External pacing if refractory as well, and certainly if they're hemodynamically unstable. If they're a candidate for ITU, and these are all these problems are adding up in a patient that isn't on high dialysis, then yeah, speak to ITU as well. Okay, can you use furosemide to reduce potassium? No, you can't. You're not allowed. Is the short answer. Truthfully, I think benzoflumethiazide is more effective at reducing the potassium. But furosemide, no, we don't tend to use that, because sometimes you could be hyperkalemic because of dehydration, and although it seems to make sense, you're just getting rid of potassium. You're not getting rid of just potassium, and sometimes physiological mechanisms get deranged. This is something I've learned as a doctor. Things aren't as straightforward as they seem. So just stick with what works, which is the insulin dex stuff. Yeah, good man. Cool. Should we move on? The next one's stressful. Can you tell? Okay, so you're carrying the cardiac arrest. Does anyone have any questions about the rest of that? I feel like I've just been talking a little bit aimlessly. You can just take a breath. Before we approach this very, very stressful one. So Dr. Mahmood, that's very kind. You're in the middle of a ward round, you're on AMU, it's a weekend shift, it's Saturday, it's 11 a.m. and your bleep goes off, beep, 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 cardiac arrest or peri-arrest, south entrance. So you immediately go, because that is your job and that is your obligation, absolutely. And you're ready to have a bit of fun. So on arrival, you see a man. He's sat in a wheelchair by the exit. He looks like he's in his 50s. He's short of breath and he's got sharp chest pain. You get there, you've got a lot of adrenaline because you don't know what you're going to see. You discover he's a patient at AMU, but he's just gone out for a cigarette. But he's got horrendous pain. So what do you do in this situation? What is the right thing to do? The man's in a corridor just by the exit in a wheeled chair. He's an inpatient, you know this, he's got a wristband. He's awake and alert, obviously, but he's in a lot of pain and he's in distress. What is the smart thing to do? He's actually sat right outside another ward as well. So there's an entrance to a ward just by you, and there's some staff that are there who called the original alarm. So call for help, LOL. I appreciate the LOL because the call for help has already happened. You are the help. And this is why my adrenaline was high. Hope that makes sense. Okay. Call for help, patient onto stretcher, attach monitors, and check vitals. Absolutely. These are all very, very smart things. What if you don't have a stretcher? Yeah, let's say there's no bed. There will be a crash trolley on the ward that is right by you as well. Could you pull that out? Would you want to? Someone said cry for the recording. If anyone watches this back at some point in the future, someone said cry. Okay, you guys are laugh. I like it. Okay, let's dial down our adrenaline. Let's stay calm. Truthfully, it's just a man having a bit of chest pain, and he's already an inpatient. So gung-ho would have been, okay, let's get him onto this ward. It's right here. Let's get the pads attached, get him in a this, that, and the other. I was there for probably about 5 minutes trying to, sort things out, and we were just talking things through. But truthfully, if you attach vital signs, if you attach all these things there and then, the information that you get from it, if he's hypoxic, you can get an oxygen tank. But if his blood pressure is low, what are you going to do about it? He needs to be on a ward, and it makes sense for him to be on the same ward. Because we were with him for a period of time, for about 5 minutes, he hadn't arrested in that time, so we took him back to AMU. And this is a situation that's going to happen a lot to you guys, actually. You're going to get called to a corridor, to a unit, to a waiting room, and it's going to be a patient, an outpatient or an inpatient. And you come in with the mind that you might have to do chest compressions and resuscitate someone. And it's quite hard to take a step back, but it's okay. Just take a few minutes. You speak to the colleagues around you. You're not the only person on the arrest team. And then you start to realize, okay, no, it's fine. We can relax, guys. Let's just take him in the lift. We went up to the ward and yeah, all was fine. but all was not fine. He was still in very severe pain. His admission reason was alcohol withdrawal and vomiting on a background of alcohol excess, alcoholic liver disease, he's a long-term smoker, and he's got ischemic heart disease and hypertension. Sharp, central, radiating to his back, down his right arm, shortness of breath. What are we thinking? To be clear, it could be multiple things. So I don't want you don't have to be super thinking of just one diagnosis. What are your differentials? Yeah, dissection's one differential. I'll give you more information anyway. Yep, ACS, MI. So these are his, this is A to E. Pneumothorax, very good, smart. PE, good. So pericarditis is good as well, actually. Yeah, I appreciate that. You've got one blood pressure, it's 148/98. Why did your F1 suggest checking the blood pressure on the other arm? What's the significance of that? Yeah, so we'll talk a bit more about that. So our differentials are all the things you guys have said, guys. So well done. ACS, dissection, PE, pneumothorax. No one said esophageal stuff, but that's just me being a bit more, looking at the other systems, because he did come in for vomiting and he's known alcoholic liver disease. There's reasons for him to have gastritis if he's got alcohol excess in his history. I hope that makes sense. Boerhaave syndrome, you get hemodynamic instability from what I've read, and you get quite bad tachycardia, you might desaturate, very, very high rest rates. I think vital signs would be worse, but it doesn't matter. What you said is you have to think about it. You have to think about it. It's definitely a differential, but it just goes further down. So you do a CT aortoangiogram, and the reason you do that is got hypertension in his history. He's got tearing chest pain on specific history taking, and this is what you find. So if the red circle wasn't there, would you be able to spot it? Probably. You guys are good. So either way, what can you see here? Yeah. So we're getting separation of the tunica, intima, and media. I think those are the two layers. I don't remember exactly, because of high pressure, long-standing trauma. Sometimes if the area's got an infection, because you can get infections. If you've got an aneurysm there, that's likely. If you've got connective tissue disease, and all that. Make sense? So how do we manage it? No one look at the next slide. Someone's got their dissection. What are we thinking? I think one thing I forgot to note is that we did the blood pressure on the other arm and it was low. It was 130. So there was a differential of about 18. Okay. So I think the cutoff for actually a blood pressure arm differential is 20. However, 18, we thought, oh, that's high enough. He's got history for it. He's got hypertension. We are concerned. We did a CT. We stabilized him, obviously, but we sent to CT. Conservative. So yeah, blood pressure management, IV labetalol for blood pressure management, fluids, cool surgeon. Why fluids? Why would you give fluids? He's hemodynamically stable. His blood pressure is fine. Where would you want his blood pressure to be? So let's say eventually he's going to get to a surgeon and we can just try and do all the things we need to do beforehand. We want to make sure his pain is under control. Thank you. The surgeons are aware, let's say. They're going to give you advice over the phone as well. They'll probably tell you to do a group and save, cross match, like you've said, well done. What are we going to do about his blood pressure? How should we manage it? Should it run high? Should it run low? Should it run normal? Because ultimately we're thinking about what the complications for this is. What are complications of dissection? Yeah, prefer BP on low side, maybe want it to be low. High pressure associated with extension of the dissection. Oh, that's clever. That makes sense, actually. So it doesn't burst. That's my kind of thinking. Yeah, well, that's exactly how I how I think. Yeah, because there's a risk of rupture. Plain and simple. Rupture equals death, I think. Sounds about right. So here's what we're doing. Wide bot access, group and save, cross match, call the surgeons, blood pressure monitoring. You can use things like nitroprusside is what is in the clinical handbook. I've never used it or seen it, but it will get used by smarter doctors than me. IV labetalol is smart. You can use that for fine titration of antihypertensives. It's really, really good. It's the kind of infusion you can run that you check the blood pressure every 15 minutes. And when it gets to the window of sort of 100, 110 systolic, you can stop the infusion and it's effective. It's done its job. That means they're no longer having that continuous labetalol. So that's how that would work. Make sense, guys? Are we happy a bit with risk factors, complications? I'll leave these for your notes. We've kind of discussed a few of these, and I'm sure that makes sense anyway. Of note, you can get embolic phenomena. You can get sort of anterior spinal syndrome, which is like spinal shock sort of thing. You can get mesenteric ischemia, I think. You can get lower limb ischemia. You can get paraplegia because of the spinal stuff, and you can get ischemic limbs as well, yeah, as well as stroke. Yeah, I'll send the slides. Tanvi will. And here I just a bit of a recap for the causes of interarm blood pressure differential. Okay, so dissection, yes. Coarctation, which is a narrowing, congenital narrowing of the aorta, usually somewhere along the arch, usually in different locations, but can be between. It can be both proximal to the left subclavian artery, meaning you get perfusion quite well of the head, but you get worse perfusion of the legs. You get weak femoral pulses and stuff. You can get blood pressure differentials as well as atherosclerotic disease. We're done. Well done. Well done to me. Well done to you. Good answers, guys. Well done all round. I'll send you the slides. Any questions? I'll sit here for however long if you need it, and we can talk about things that we've talked along the way that are jocks in earlier on. Oh, you're welcome. You guys are very kind. There's additional, I've got references and guidance, a few images of some of the PubMed articles I got information from, as well as Life in the Fast Lane for some of the ECG stuff. A few notes on specific drugs that might be really worthwhile memorizing, just for your work, not necessarily for exams. Specifically the 10 mils, 10% calcium gluconate over 5 minutes, however long, and the insulin dex, because the panic you get when someone's hyperkalemic is real. So you don't want to have to sit at a computer and look at guidelines to double check this stuff or Google it. Google it. And a few random slides. Cool. Remember to fill out feedback as well, guys, yeah? Do I need to stop sharing? Maybe. I think actually, guys, the slides are right at the beginning of the chat. There's a PDF of the slides, and yeah, there you go. It's there again.